Maternal health is a high priority for AHA and its member hospitals and health systems. As part of that commitment, AHA has long partnered with national organizations as an active member in the Alliance for Innovation on Maternal Health, also known as AIM. To date, the field's collective efforts have largely focused on in-hospital maternal morbidity. That work is foundational, and recent data shows that morbidity and mortality is declining in some regions of the country. However, the opioid epidemic has created a new challenge. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hetterly, senior writer in AHA's Washington office, and your podcast host. In the United States, one infant is born every 15 minutes with withdrawal symptoms after being exposed to opioids before birth, according to a new study published in the journal Pediatrics. Typically, affected neonates must remain hospitalized, usually in neonatal intensive care units, for monitoring and management of opioid withdrawal symptoms. Hospital length of stay for these neonates averages 17 to 23 days. Today, we'll hear from Dr. Stephen Patrick, an attending neonatologist at Monroe Carell Jr. Children's Hospital at Vanderbilt, and director of the Vanderbilt Center for Child Health Policy. His National Institute on Drug Abuse funded research focuses on improving outcome for opioid-exposed infants and women with substance use disorder and evaluating state and federal drug control policies. He previously served as Senior Science Policy Advisor to the White House Office of National Drug Control Policy and has testified before the U.S. House of Representatives and Senate on the rising number of newborns being diagnosed with opioid withdrawal after birth.
Hello, this is Rebecca Chicky with the American Hospital Association. I am the director of the AHA section for Psychiatric and Substance Abuse Services, and I would like to welcome and thank in advance Dr. Stephen Patrick for talking with me.
Great to be with you here today.
Tell me a little bit about yourself, your current role, and what drew you to work in the area of Neonatal Abstinence Syndrome, otherwise called NAS.
I'm a neonatologist at the Monroe Carell Jr. Children's Hospital at Vanderbilt, and I also direct the Vanderbilt Center for Child Health Policy. What drew me to neonatal abstinence syndrome initially was my clinical experience. We started seeing babies in the neonatal ICU who were having opioid withdrawal, and that's just different than the population we generally see there who are born very preterm or with complex birth defects. And that got us asking the question, what was different about these infants? How are they ending up in our neonatal ICU? What was going on outside of our ICU that may be contributing to this? And that started a journey for us, looking at multiple different factors that led to infants being in our ICU and how we could improve outcomes for both mom and baby.
Building on that, can you describe the impact of NAS more broadly? What's its impact on maternal mortality, on child health, developmental challenges, even the economy and social implications?
NAS in many ways is a canary in a coal mine. We know that the opioid crisis is having a broad effect on the entire U.S., and that's true for pregnant women and their infants too. Over the last 15 years or so, we've seen a quadrupling in the number of pregnant women who have opioid use disorder. And increasingly, we see states identifying deaths from overdose as a key driver of their maternal mortality statistics at the state level. So it's a substantial challenge to maternal health. For infants who are exposed to an opioid in pregnancy, sometimes develop a drug withdrawal syndrome, and that's neonatal abstinence syndrome. And that's a clinical syndrome that is characterized by jitteriness, inability to feed sometimes. That can lead to dehydration and poor weight gain and prolonged hospital stay. So that's the immediate impact. So if you step back, we have this challenge for moms that can be life-threatening, where they are at an increased risk of overdose deaths and oftentimes have a challenge in terms of getting the medicines they need to reduce that risk of death. For infants with neonatal abstinence syndrome or drug withdrawal after birth, their challenge is less acute if they are identified. Neonatal abstinence syndrome is a treatable complication of opioid exposure, but it has to be identified and treated appropriately immediately after birth. Those challenges are pretty acute during that time period. It's true that there are some questions in terms of developmental challenges long term, But that's an area where we need additional research. We do have some data from older studies, some of which are confounded by other exposures like alcohol, that suggests there may be some subtle changes to attention, perhaps IQ, and verbal processing. But that's an area where we need large prospective studies to really understand those developmental challenges. When we think about the economic and social implications, they are broad. Caring for infants with neonatal abstinence syndrome in the U.S. per year is around $500 million just for the birth hospitalization. And about 80% of that is paid for by state Medicaid programs. What's important about that is it really places states and state policymakers at the key intersection to begin to stem the tide of this crisis for pregnant women and infants. And the social implications that we were talking about are certainly broad too. I think once you step back from this isn't just a medical problem. It's a social problem that has many layers to it that we can begin to unpack too.
To unpack it, can you bring this home in a more personal way? Could you share a patient story to bring this crisis and the importance of your work to life?
I think pretty clearly about a patient that I encountered. It was about 2 years ago now. This was an infant who was born and was in our newborn nursery and had some classic signs of drug withdrawal. Infant was irritable, was losing weight, in fact lost about 10% of his body weight within the first 48 hours of life, was not feeding well, and came to the neonatal ICU because of poor feeding and jaundice. When we talked to the newborn nursery attending, we asked them about any potential substance exposure, and then I asked the mom too when I met her. And the mom denied any potential substance use during pregnancy aside from caffeine. What became clear in taking care of that infant was having pretty classic signs of opioid withdrawal. But the mom was reluctant to talk about her substance use. In about a week of life, one of our drug tests came back. We can test the umbilical cord for substances. And it came back for buprenorphine, which is a medication, it's an opioid medication that people use to treat opioid use disorder. And when I walked into the room to talk to the mom, the complexity of the situation becomes real. The mom immediately broke down into tears and asked about whether or not she'd be able to take her infant home and began to talk about some of the challenges she had. If we step back from that, we begin to understand some of the layers about why women aren't forthcoming about substance use. The first is the stigma about that, being able to talk about substance use disorder. The other issue is just trying to get treatment. We know from some of our research that getting access to treatment, including opioid agonist therapies like buprenorphine, is really challenging in many communities. Oftentimes providers are cash pay only, and particularly in rural communities, it's complicated. We've also seen a dramatic rise in foster care placements and removals nationwide because of parental substance use. And so we see this challenge of how do we begin to deal with this proactively to try to keep moms and babies together when that's possible and when it's safe for the infant. And you see all these layers of complexity where, this isn't a terribly medically complex problem to care for in many cases. That infant, aside from not having a clear diagnosis at the very beginning, wasn't terribly complicated to support and take care of. It's the other challenges that happen prenatally and after discharge that can be really challenging. And that's where we focused a lot of our work to begin to unpack what's happening in communities and how can we optimize systems of care prenatally and post-discharge to be able to improve outcomes for both mom and baby.
Building on that, could you share a little bit more about the extensive research that you have done in this area? Not only what you've learned, but share your perspectives on what the health policy and clinical care implications might be from the findings of your research.
Our research team has tried to focus on the continuum of care for both pregnant women and infants affected by the opioid crisis. We've done some work evaluating state opioid control policies like prescription drug monitoring programs. Increasingly, we're looking at work to try to understand what are barriers to access to treatment for pregnant women, and also some work to try to improve outcomes for opioid-exposed infants. What we found is that some state policies are effective in reducing some opioid mortality. Those are prescription drug monitoring programs, have been effective at reducing the risk of death from prescription opioids. We've also found that pregnant women have a challenging time to get access to treatment, particularly in Appalachia. We did a study of all opioid treatment programs in West Virginia, Kentucky, North Carolina, and Tennessee, and a sampling of outpatient buprenorphine providers. In that, we found that only about half of providers would take any insurance at all, and only about half of providers would take pregnant women. This just shows some of the challenges that I think pregnant women face. In some of our work around neonatal abstinence syndrome, we first focused on the rapid change of neonatal abstinence syndrome nationwide, just to understand the scope of the problem. And in our work, we found that the rate of neonatal abstinence syndrome grew nearly eightfold over the last 15 years. And in 2014, about one infant was born every 15 minutes having drug withdrawal, accounting for more than $500 million in hospital charges. Again, I think that highlights, how we may be able to spend our dollars differently. When we only began to react to the problem in our hospitals, we're using resources both inefficiently, and we could do a better job in spreading our resources both prenatally and postnatally, perhaps saving money for the health system and improving outcomes for both mom and baby. And I'll just say this, the other thing that we've been working on more recently is understanding some of the post-discharge needs for mom and baby, including how we can identify some opioid-related complications like hepatitis C for both mom and baby and improve systems of care for both of them. To think about policy change, again, unwrapping the layers of this are complex. When we think about policy change, I think about it in a couple different ways. The first is primary prevention. How can we ensure that we reduce the amount of opioid prescribing that we're still doing in the United States? We've seen decreases in recent years, but particularly for acute conditions like broken bone or tooth extraction, how can we make sure that we only use opioids when they're necessary and appropriate? That's true for the general population. It's true for pregnant women as well. How can we work to expand access to effective contraception like long-acting reversible contraception? And then when we think about treatment, I think targeted resources, targeted programs just for pregnant women are important. Having comprehensive treatment programs is pretty rare in the United States. And I think in part that's because oftentimes addiction medicine doctors are not comfortable taking care of pregnant women and obstetricians are not comfortable taking care of addiction. And so we have a long way to go to begin to improve those systems of care. We have seen some policy changes over the last couple of years that have been pretty positive. The Support Act that was just signed into law a few months ago has a lot to like in terms of maternal and child care related to the opioid crisis, including some pretty substantial changes to the child welfare system and funding for them. So I think we are beginning to see some things that are very positive.
The American Hospital Association was a large supporter of the Support Act, so I definitely concur. You have highlighted just a few things that hospitals and health systems can do to address neonatal abstinence syndrome, both for mothers and for babies. But could you share a few more examples? And additionally, what aspects of your work do you think could serve as a model for others combating this multitude of challenges around this disorder?
I'll talk a little bit about some of the things that we've done at Vanderbilt. And what we've done is try to apply some of our research, but also learn from other hospitals and the really positive programs that some of our colleagues, Dartmouth and Boston Medical Center, have done. About a year and a half ago, we launched a program that we call Team Hope. And all opioid-exposed infants that are greater than 35 weeks who don't have another problem, and like a respiratory problem, they don't come to the neonatal ICU at all any longer. They room in with their mothers first in the newborn nursery, and then in the general pediatric inpatient floor. We were able to get funding from a private foundation that was matched by our institution to hire a child life specialist and a part-time lactation consultant so that we began to focus on keeping mom and baby together, supporting breastfeeding when it's appropriate, and supporting the family through a child life specialist, as well as building out a volunteer program to help support our nursing staff. What we've seen in the last 18 months is that we've decreased our length of stay pretty substantially. Our length of stay for neonatal abstinence syndrome overall is about 13 days, about half of where it was before we started. We see high rates of breast milk use among eligible moms. About 80% are using breast milk at the time of discharge. That's a big improvement for us. And this program has also helped us break down silos in care. We have a wonderful clinic for women with opioid use disorder at Vanderbilt. And we've been working together with them throughout this program to unify our protocols around things like breastfeeding, as well as help our communication with each other and beginning to engage community partners like our child welfare system and local treatment facilities. For us, what we've seen is both greater efficiency in the care that we're delivering and greater happiness in terms of both the care providers as well as the families, because we're engaging them differently. We are now beginning to focus in on discharge. So if we are, as we're sending infants home, how can we do a better job of coordinating their care and having a safe handoff to local pediatricians, to early intervention systems, and so on and so forth. And so that's been a pretty substantial shift for us. Infants no longer coming to the NICU. And in our NICU, we have, a census that runs in the high 90s on a regular occurrence, and we were having up to 10% of our infants having drug withdrawal in the NICU. So that's a big shift for us. And in the last 15 months, we've had around almost 200 infants that have come through the program. So kind of indicative of the population we serve here in Middle Tennessee.
What are your future plans for your work in this area? And additionally, how can anyone listening to this podcast learn more about the work you've done here?
So a few things. We will continue doing research to try to improve care for moms and babies. We're doing some further, more detailed work on trying to understand barriers to access to treatment for pregnant women. We're also working to develop tools to optimize the care for the infant, including a clinical prediction rule that we're finalizing now so that we can do a better job of tailoring our treatment to infants who are opioid exposed shortly after birth. We are also beginning to make our clinical programs more robust. Like I just mentioned, we are focusing on our discharge processes. In that work, we found that we weren't doing a great job of doing everything thoroughly. So if we think about an optimal discharge in terms of transitioning to home nurse visitation, a primary care doctor, making sure there's hepatitis C follow-up and testing for the infant, we weren't doing a good job consistently with that. As we begun to focus on that, we're doing a much better job of that, and we will continue to work on those partnerships long term. In terms of trying to understand more about what we've done, people can email us at childpolicy@vumc.org. They can also look at our website, which is www.childpolicy.org. And they can also follow us on Twitter at VUMC Child Policy.
Dr. Patrick, thank you so very much.
Great to be with you here today.
Not only do we want to thank you for your willingness to share your inspirational work and experiences with all who are listening to the podcast, but we also want to thank our audience for being engaged in this very important topic. If you, the listener, would like to learn more about the work that AHA is doing to improve maternal and child health, as well as improve access to behavioral health care, please visit www.aha.org. This and future podcasts on this important topic will be available there, as well as on AHA's podcast channel, Advancing Health.